Hi everyone. So what we are going to talk now is about COVID-19, the management of it in intensive care. We'll divide this talk into three different small video clips. The first we'll talk about the clinical presentation of this patient, which is basically severe hypoxemia. The second part or the second video will be about the ventilation management or ventilatory management. And the third one we will talk about the non-ventilatory part specific to COVID-19. So coming back to the first one, which is the clinical presentation of severe hypoxemia. Now what we have been understood or we have been told from the Chinese experience that, or even the Italians, that from the respiratory point of view, these patients are like severe ARDS. But what we are seeing now is slightly different. That COVID-19 is not equivalent to ARDS as such, because the disease of COVID-19 has various phases, and the patient can present to us, to the intensivists, intensive care physicians, at any of these phases, because they can be hypoxemic in these three different phases or two different phases. So mainly the two classical difference phases have been divided into two phenotypes. One is called the L phenotype and other is called the H phenotype. The L, which stands for low, in that phenotype what we see is that they have a low elastance or their compliance is reasonably good, or compliance of the lungs. Next, the ventilation perfusion in these patients are very badly mismatched or very low. If these patients get intubated, it's difficult to recruit them, or rather they are not recruitable. And lastly, they don't respond to higher PIP. So this is the typical L phenotype classification. And the H one is just the opposite, where the compliance is poor, so they are typically like a ARDS patient. They respond to good PIP. There is a shunt from right to left, and they are recruitable. Another element which we need to talk about in the L type is what we see is these patients have lots of pulmonary microthrombi, and that increases the dead space, and that is an important part in causing hypoxemia in this group of patients. And this is important because when we look into the management type, we will see how it can be beneficial. So a patient in this can come to us at any phase. Now how do we know patient at which phase they are? We have several aspects. The first one is history. Is the patient presenting to a severe hyperacute phase? Has the symptoms just started a day or two before and has come to us or to the ED or to the AU and then to the intensive care, the severely hypoxemic? Or is this patient is now in day 6, day 7 from the onset of symptoms and they came to us? That gives a clue where the patient stands in this continuum process from L to H. Next is that if you look at the PF ratio for both of them, they will be equivalent. Whether the patient is in H type or L type, you may find they are in the equivalent stage. PF ratio may be low for both of them. But if you do a chest X-ray, and I will show you some chest X-ray or a CT scan, you will see that in the L phenomena, well, you have some infiltrates, but they're not that bad. Whereas in the H phenomena, it's a classical ARDS picture you can see on the chest X-ray. So that's the difference you can make out from the chest X-ray where this patient stands. Mind you, both of them are severely hypoxemic. So if somebody is not hypoxemic and day 10, day 11, you are having a similar X-ray to that, that means the patient hasn't gone into the H type or will get better. It doesn't have to go into H type. And if you look at the CT scan, you can see here, all these three CT scans are severely hypoxemic patient. But look at this scan, hardly anything wrong in the lungs. But look at this, is classical ARDS phenomena. So you can see that atelectasis or rather the alveolar closing up, so complete compression of the dependent area. Whereas here, we can still see that there's no problem. So this is probably a ventilation perfusion mismatch happening there. So this is what we see in terms of the hypoxemia. The next element is important is we talk about is a respiratory drive, and that allows us to in the assessment of this patient. Now what is classical in the respiratory drive, that sometimes this group of patient may have a high increase in work or breathing, but if you speak with the patient they don't perceive that, and that phenomena is something called as neurotropism. So what they are saying that in the midbrain we have the respiratory center and then we have the cardiovascular center. So the release of the neurotransmitters doesn't allow the patient to perceive that they are dyspneic, or rather perceive that their work of breathing is high. So they will have a high tidal volume generation, but they will not perceive that they are dyspneic. So that is an important us to assess, because patient may feel they are saying they are feeling good, but their work of breathing is high. So that means along with that low saturation may tell us that this patient may need to be intubated earlier. So you have to keep that in mind. So what we have discussed now so far is this different types of hypoxemia in this group. Now going forward in terms of looking at the severity of the hypoxemia, how do you do that? So as I say, the hypoxemia patients both in L type and H type are severely hypoxic. But how they can present to us, I'll just change it and show you. Let's say for example, in the y-axis is the severity and in the x-axis is your number of days. And this is severity. So in the L phase, we may present with somebody severely hyperacutely hypoxic, so their severe is very high and they are going downhill like that. And this is the classical, they have high respiratory rate, severely hypoxemic. Then another phase, which is called the indolent phase. So this group of patient may be moderately hypoxemic to start with, but then they're slowly improving and they will get better. And the third group of patient, which comes into the phenotype H1, that they may start with the indolent one, they may improve slowly, but after day 5 or day 7, they suddenly started to getting bad again or worse again, and then they go with severe, and we will see increase in inflammatory markers in them. Your lymphocyte count may be high. So if we get a patient whose lymphocyte is high, but they are here, initially they looked all right, so we may be misled. This patient is not COVID, but probably this patient is COVID. The lymphocytes and the inflammatory numbers are high up because this is quite down the line. So that we have to keep that in mind. So that's how we differentiate look at the severity of that. Now when you're talking about severity of the hypoxemia, how do we know how severe they are in the bedside? And for that we can do something called oxygen challenge. So what we can do in the ward or even ED, that if suppose this patient comes and is saturating around 90, 88, 90 on a room air, we give oxygen to them and you give 15 liters by a rebreathing mask and see the response. If the patient saturation now improves to more than 95, 96, because of that oxygen challenge, we can say with some authority this is a mild form of severity. Whereas if the saturation doesn't improve, then we can say this patient is severe because the shunt fraction here is quite high. And that's why the patient is not improving, or the hypoxemia is not improving. So that is how we can do. So to summarize what we have just seen, that we can see that the hypoxemia in this group of patients are two types, the L phenotype and the H phenotype. We then have seen that to differentiate that, we look at the X-rays. They can be different for these two groups. The inflammatory markers can be quite different in these two groups, with the L type having a low lymphocyte, the inflammatory markers are not high, whereas in the H type you may have the other way around. And lastly, that how we can know how severe is the patient's hypoxemia is by giving an oxygen challenge. So that ends this part of the video. Thank you. Hi everyone again. So as the second part of our COVID-19 management in the ICU, we'll talk about the ventilatory management of this patient. So in the ventilatory management, so as may have seen the patient severely hypoxemic, they have asked us to review in the ward and we are deciding what to do. Some instances it will be very straightforward, let's intubate, and some instances we may be slightly in the gray zone. So what we do there, we look at the walk-up breathing. So if the walk-up breathing is low, then we can think of this patient will be benefited with a CPAP. So the CPAP can be started in the ward as we are planning to, depending upon the availability of the patient. Or if you bring the patient to the ITU, we can start CPAP. But the very important aspect here is that the CPAP should be time limited. By that, I mean the patient should be reassessed on a regular basis, maybe every hourly. What is the walk-up breathing? Is the patient improving? Because if not, then what CPAP or NIV can cause, they can cause something patient-induced spontaneous lung injury. We always knew about ventilator-induced lung injury, but this is spontaneous lung injury because of the patient is taking very high tidal volume, lots of stress and strain. So that is an important aspect. So if the patient is at the walk-up breathing, low, we have given CPAP. But if the walk-up breathing is high, then we have already decided the patient needs to be intubated. Or if the CPAP fails, we decide to intubate. So intubate as per the way we intubate this group of patient. After intubation, when we started this patient onto a PRVC mode, which is pressure regulated volume control mode, the first thing we need to look at it is what is the driving pressure. Now yes, you have started your this patient in the breathing mode of respiratory rate somewhere to get an tidal of less than 6 or around, your tidal volume which is around 8 ml per kilo to start with, and once you've done that, we look at the driving pressure. So what is the driving pressure? Is it less than 15 or more than 15? In the servo-I ventilator, we can see this driving pressure by first finding out the plateau pressure. So the driving pressure by definition, for those who don't remember, is the difference between the plateau pressure minus the PEEP. Now plateau pressure is the pressure in the alveoli. So in the servo-I ventilator, look at the pressure waveform, hold the inspiratory hold, and at that time, whatever the pressure is coming, it is the driving pressure. Whereas in V60, we cannot know the driving pressure by that way, to be honest. Anyway, so we look at the driving pressure and see whether it's less than 15 or more than 15. So this gives us a screening tool. So if the driving pressure is more than 15, that means the lung is probably now quite less compliant. So in these cases, we reduce the ventilation to 6 ml per kilo of predicted body weight, the tidal volume, I mean. But if the driving pressure is less than 15, we continue on 8 ml per kilo. Now, as time progresses, if the patient's condition worsens from breathing point of view, we look at a situation where we are waiting and seeing the FiO2 requirement has gone up, saturation is still low. When up, I mean around 0.7 or 70% of FiO2, or saturation is still around 88 to 90. Then we think about where to go next. So while we are doing that, you can increase the PEEP if you want, till you get help from a consultant or senior. You can increase the PEEP, but no point in increasing the PEEP to more than 40 in this group, that is the high compliant group. Whereas in the low compliant, which is the low driving pressure group, high driving pressure group, you can increase the PEEP more, but ideally if you increase the PEEP to 14, wait and see, the next stage comes. And the next step here is to look at the compliance. So what is the compliance? Is the compliance more than 40 or less than? In the servo-I, the compliance parameter comes onto the monitor, which you can see. Whereas in the V60, unfortunately, you have to find it out, or then it becomes the static compliance, that is tidal volume divided by the driving pressure. Now if the compliance is more than 40, then you know this is a L type. Again, that is another screening tool. So it's a L type. So yes, in that situation, we prone them early. That's the first thing we should do in the L type. The reason is the proning will help this patient by increasing the pulmonary perfusion. Mind you, these patients have also lots of dead space, maybe lots of microthrombi within the pulmonary vasculature. So proning is the way forward. The next, if that along with that, we can also use inhaled nitric oxide. Now we are not having that in our trust at the moment, but I have asked around to think whether we can get some more. But our experience from previous, yet we have used prostacyclin instead. The problem with prostacyclin, inhaled prostacyclin, is that it causes crystallization within the circuit. So as a result, many centers have now moved back to the normal humidifier with the HME filters. So that's something which you have to think ahead if we come to that situation, but we need to think ahead now probably. So the treatment here is prone early, and inhaled nitric oxide, which problem with inhaled nitric oxide, they work well in the first 3 to 4 days, then tachyphylaxis sets in. Another element in proning is that this patient, which is a L-type patient, when you go back to supine, they don't do well for that long. Now in our prone position protocol, we say that we prone for 12 to 16 hours, preferably 16 hours, and then give a gap of 6 hours, then do it again. But probably it doesn't work. They start to become hypoxic quicker. So if the other side of the compliance, when the compliance is less than 40, that means have a stiff lung. So there we can do the recruitment maneuver, because they will tolerate a much more higher PEEP, 16, 18 if you want, go ahead. But in those group also, we probably will prone, because prone helps them, those group by recruitment, by recruiting the alveoli. So in this group, what we will see that when you prone them, and then after proning, the hypoxemia improves, but when you make them supine, they stay longer with a good oxygenation. So that is the difference classical in the proning and unproning of these two groups. So even after doing this initial bit, if they don't improve, they become refractory hypoxemic, you can wait for 6 hours to see how they are. And if it's not improving, we may need to the next step, which is the ECMO. And then change our other strategies. So that is the classical ventilation strategies of this group of patients. Lastly, I will talk about the extubation. So if they are improving, thanks God, they are doing well. How do we extubate? Now in our guideline, we have made some very clear demarcation that we will wait a bit longer. The reason behind is, first of all, we don't want aerosol generating procedures after that. We don't want this patient to go back to CPAP or high flow. This is number one. But the number two also is that we need to ensure that their airway is quite good, because what they have, we are seeing that many of these patients has been reintubated. Italy has reported a 30 to 40% reintubation rate, which is a high. And one phenomenon which we are seeing in London and other places, that there is a lots of airway edema. As a result, they are giving dexamethasone before extubation. And also, they are keeping in some places, they are keeping nebulized adrenaline ready, that if they have a problem. But from our point of view, what we need to do, we need to make sure that we do a cough leak test in this group of patients. And then we decide, if the leak test passes, we decide to extubate. Keeping the other phenomena, which are other points, which is making sure that the FiO2 is less than 30% or less, and the PEEP is around 5. So that's all about extubation. And with that, we finish this video on ventilation. Thank you. Hi. So this is the last of the series of 3 videos which we are doing to discuss the intensive care management of COVID-19 patients. So in this video, we'll talk about the non-ventilatory management of this specific group of patients. And the topics we'll discuss through are the blood pressure management, fluid balance, renal replacement therapy, and microbiology. So many of them are interrelated, especially the blood pressure and the fluid balance. So to start with blood pressure, we have to be very clear that we should not manage all of these patients in the septic shock guideline. Some of them may develop sepsis with a superadded bacterial infection and may behave like a septic shock, but not all of them. So you have to make it very clear. Next, targeting the blood pressure is still the same, of course. The mean arterial pressure of 65 and above. We give fluids and we also use vasopressor. In terms of fluid, we keep the hydration to be optimal. We want them to be euvolemic. We don't want to be superly hypervolemic, but euvolemia is the target. And using vasopressors, we can use noradrenaline as we normally use. But here, from experience, what people are finding, that if we need an escalating dose of noradrenaline, we should bring in vasopressin earlier or add in vasopressin. The reason behind is vasopressin has more positive effect on the pulmonary vasculature and the renal vasculature. And talking about fluid balance, as I mentioned already, our aim, especially when in the initial phase they are coming with severe hypoxemia, to manage them or maintain a euvolemic state. And we can know the volume status by using echo or lung ultrasound or straight leg raising test. Because mind it, wearing all these PPEs, it may not be easy to ascertain is the periphery feel cold or warm and other aspect. So talking about this fluid balance, to add in, we have to remember that when we see the patient in intensive care unit, the patient may have a lots of fluid loss before coming to us. If this person was having a temperature of 39 and 40 for 3 days, the amount of insensible loss is quite high. Some of them do have diarrhea. So keeping all this into account, we need to ensure that we manage the volume state as well. And why so? Because initially the Italians said they did not require good amount of renal replacement therapy on them. It's a single organ problem. Whereas what people in London are finding it now, that the use of renal replacement therapy is around 40%, 25 to 40%. It's a huge number. So the concern is that we are not causing any iatrogenic AKI by keeping them too much on the drier side or bringing in fusemate too early. So we have to see that on a case-by-case situation. Next is using the renal replacement therapy. As you are seeing, we have to use more in our population group. So one important but a very classic problem is crept out is the use of citrate as an anticoagulant. Most of the hospitals in UK use citrate nowadays, but what we found that even citrate, the circuit of the dialysis machine gets clotted quickly. As a result, many hospitals are using systemic anticoagulation, not the anticoagulation in the circuit, it's in the systemic anticoagulation by monitoring ACT, because COVID-19 is a hypercoagulable state. In our unit, we haven't decided for that yet, but we will see that how time goes in, what to do. But we have to are very clear, we will not use citrate in this group of patients. Going forward is about the microbiology, that we should use procalcitonin or PCT to guide our antibiotic therapy. Remember, most of these patients will be started on broad-spectrum antibiotics as they come through the door of ED or acute medicine. But using PCT, we may be able to manage the antibiotic stewardship better. Yes, there is a good element or good number of patients who are coming up with a false positive. When I say good number, it is not a huge percentage. You don't know, but it's roughly around 20-25% with a false positive. As a result, we may not be sure whether you should stop the antibiotics or not. But the other problem which is crept out, because they are managed in the ventilator for longer duration, the fungal infection, the superadded bacterial infections are coming out. So you have to keep that in mind. So use PCT and guide accordingly. You may have to raise the marker of the PCT level to around 1 to see whether we are stopping or continuing the antibiotics, but that is one important aspect. So to end, I would say that this is a very early stage, and beginning of April, this video is, we are doing it. Some of these experiences and the evidences may change as time goes by. So in the end of April or May, this video may not be of any use. But what will be very, very useful, which will never change, is the basic management of this patient. It's a basic intensive care management. Mind it, we are stretched to the end. So one ICU nurse is looking after 2 or 3 or 4 patients with the help of non-ICU staff. So as a doctor and as a nurse, we need to make sure that we do the basics properly, and if the other bit is not done appropriately, we can still excuse us. We should not feel too bad, and we need to support each other to get out of it. Thank you.